NAD precursors should only be given for the ones who need it, because who is charging their smartphone if it's 100% charged? Or who is charging their electric car if the electric car is 100% charged? Don't do it via the infusions. Oh, very important.
Yes, this is a really great point. Go on.
So when I'm talking about NMN or the supplementation with NAD precursors, I'm talking about tablets, talking about capsules to orally being given. So there is the practice at the moment in many clinics who just say it's easy, quick and easy, and dirty, I would say, and especially dirty. You just give it via an infusion and a huge amount of energy. There's only a couple of studies, and one in particular, which actually did not bring the evidence that it's actually useful. And we only have studies with oral supplementation. And also from a physiological perspective, it does not make sense. I wouldn't know what so much of NAD precursors would actually do in the bloodstream, because it has to be resorbed. We have to feed our microbiome. And if you're giving it via the infusion, like no microbe will actually touch it.
Welcome back to the Women's Handbook podcast, How to Be a Woman, where we discuss everything women's health from menarche to matriarchy. I'm Dr. Natalie Hutchins, and today we are talking all things women's health longevity. Now, when longevity first started making waves in the media a few years ago, I'll be honest, I was a little sceptical. It felt very experimental, and it also felt like something designed for a very specific type of man. But I was intrigued enough to delve into it further, and I've actually now come around to the idea that this is going to be the future of my profession in primary care, and a really important part of the future of women's health. I think so much of the hype that we see isn't actually longevity medicine. It might be a small part of it, but it certainly isn't the foundations of it. And it can be accessible and relevant to all of us. So I really want to bring you on that journey with me. And to do that, I'm joined by Professor Andrea Maier. She is a world-leading geriatrician and longevity researcher, and she is one of the most influential scientists shaping the future of aging. So let's get started. Hi, Andrea. Nice to have you with me today. Thank you very much for joining us.
Nice.
So I just wanted to start at the beginning by getting you to explain to listeners what it is that you mean when you talk about healthy longevity medicine. Because I think for a lot of listeners, when they hear the term longevity, their mind will instantly go to things like NAD or expensive supplement stacks or peptides, or they might even be confused by some of the newer specialties like integrative medicine or functional medicine and not understand what the difference is between that and healthy longevity medicine. So why don't you tell us, when you talk about healthy longevity medicine, what do you mean by that?
So great if people think, if you hear NAD, that's healthy longevity medicine, because it's absolutely included. So that's great.
Yeah.
So healthy longevity medicine is a new specialty, which is not yet recognized by in many of the countries. But it is optimizing health and health span of aging individuals. And what does it mean? It's health and health span. So health has to be defined. Health span has to be defined of aging individuals. So it's about you and me. It only includes adults at this moment in time, not the children. And very importantly, and that's the difference between functional medicine or everything else you just said, is antagonizing the aging processes. So it's rooted into geroscience. Geroscience is the biology of aging. How do we age? Why do we age? Especially in animals, we transferred that to humans. And while understanding the biology of aging, we can, I think it's unethical not doing something with it. So bringing that science into medicine, and that's in the end healthy longevity medicine. And I want to make it even more complicated. Healthy longevity medicine is a public term.
Yeah.
And the academic term is precision geromedicine.
Okay.
So precision medicine is now known. We are all unique. You are unique. You are very different from me.
Yeah.
We are very different from men. But every woman is unique. So we need precision in medicine. And then we added gero in front of the medicine. And gero is aged aging, comes out of Latin and Greece. And then it is precision aging medicine.
Yeah.
So that's the specialty we are bringing into the healthcare system to really optimize the health of individuals, including males and females.
Yeah, absolutely. I think one of the things that really won me over when I started coming to your conferences was that women's health and longevity from the female perspective was a central theme throughout these conferences. And I think in generalist spaces, that tends not to be so much the case historically. Women's health has very much been kind of a niche or a specialist thing. That's what the gynecologists do. And women's health has been seen, predominantly through a reproductive lens. And it's so great to see that changing now. Do you think that attitude and the way that we have historically looked at women's health through the reproductive lens has kind of held us back into understanding women's healthy longevity?
Partly. What we realized in the past 20 years and quite late, that sex really matters. So having a Y and an X chromosome, it really matters. And we in healthy longevity medicine, in precision geromedicine, the precision medicine already states it. We have to look at the individual and therewith at sex and gender. And that's also the reason why it is so on all the agendas in conferences, in talks. So, of course, there is a revolution that women stand up and say, hey, we are more than just infertility problems. We are creatures who want to live after our 50th birthday, and we want to feel well after the 50th birthday.
And I think just in the general kind of space of talking about medicine and recognizing that, as you say, gender and sex does make a big difference. And actually women haven't been studied, and that area of health has been underfunded. And I suppose it's also come from the fact that women are a little bit more vocal about wanting to have that research there. So it's great to see that.
Yeah, but that really changed. So I always, as a geriatrician, said, okay, we don't include the older individuals in trials. So we are giving meds, even statins, to an 80-year-old with lots of other medications and never actually studied it. How can that be? Same also holds for other majorities, but also minorities. So we just have to make sure that we do the research in the ones who are actually taking the interventions, and that's most important.
Absolutely.
And that absolutely changed with really the arena of evidence-based medicine, that we are really tackling the root cause. What is another medication do with something else? What are the side effects, and being really inclusive. And I would say that the entire idea, we cannot include women because they are so complex. I don't say complicated, but complex because of cycles. And then they have their psychology, and then they don't want, and they ask difficult questions. I think that's gone in the modern era of medicine, and also how to do trials.
Hooray. I wanted to talk about the fundamental shift in the central organizing principle of healthy longevity medicine, or geroscience, which is, well, what I've taken it to mean is that you have fundamentally shifted away from that traditional way of understanding and assessing the body and chronic disease from systems to the underlying cellular mechanisms. So when you talk about the underlying problems, when you look at chronic disease and disease of aging, you're not actually just going, right, well, heart problems, cardiology, and let's talk about that. You're actually looking at the underlying mechanisms. Can you talk a little bit about that? Yeah,
sure. I'm a absolutely professionally trained normal internal medicine specialist. So, and I was always quite happy and especially satisfied coming from the emergency department, having lots of adrenaline, and said, I really took care of X amount of patients, and I solved 10 cases where I really had the impact that they did not die.
Yeah.
And I loved it. And then I had the aha moment 15 years ago. I didn't solve anything. I was in parallel already doing aging research, really understanding the fundamental basis of why we age, what our fibroblasts are doing in our skin, and why we have wrinkles and everything else. But then that fundamental understanding, I have this family thanking me because I did something great in the emergency department, towards that understanding I did not do great, because I should have done great 5 years ago, actually, to prevent that event. That was such a tremendous aspect in my life that I said, okay, I really now have to bring it into clinical practice. And I failed miserably because nobody was really, I was not prepared. I think the systems were not prepared, saying, okay, I want to see this individual now in the emergency department with chest pain and with a stroke and so many other symptoms. 5 years, 10 years earlier. And I even want to see their offspring to actually prevent their functional decline. It was just too far. But what we in parallel in the last 15 years really understood is why we age. So we can prolong the aging process. There was the lifespan of a C. elegans, which is a tiny worm, or a Drosophila, or a mice, by 20 to 50%. It's not a problem. So we really understand how to manipulate the biology of aging. Bringing that concept into clinical practice is a huge jump, especially in the absence of really good trials in humans. So we had to work a decade on how do we translate what we know of a worm, of a goldfish, or a monkey, or whoever, into the human beings, and really learning from observational studies and learning from, in the end, randomized controlled trials to see what worked. So also it's good that 15 years ago I didn't implement what I wanted to implement, because I think the science was also not right. And we then coined the term geroscience, understanding the biology of aging. And from that understanding, moving to humans, we were able to involve the first tests. Of course, 15 years ago, I did the first genetic test with my patients. And then we said, okay, let's look at the microbiome, for example. Let's look a little bit deeper than just a stethoscope every physician has, and just listening to the heart. And every physician should still do that, listening to the heart. It's so exciting, like it's real life. But then understanding why the heart rate is like this and what the heart rate variability is, with getting digital devices. Think about the first pedometers we had 20 years ago in clinical practice, not asking how many steps do you actually take every day, but measuring it. So there was an evolution, and then borrowing little diagnostics from all the different subsets, from the technology nerds with the pedometers, with new softwares to actually analyze data better. Like roughly 5 years ago, there was an inception of health and longevity medicine, bringing all the tools together, finding a term which would really acknowledge the biology of aging, and then defining all the secrets we could actually do in terms of gerodiagnostics, so measuring how old you are, and then also finding the therapeutics and matching them.
And you call those the hallmarks of aging, don't you? So can you take us through some of those processes?
So first we had 9 hallmarks, 3 hallmarks, 9 hallmarks, doesn't matter. Now we have 12. Somebody says we have 20, doesn't matter. But we understand the hallmarks, the fundamental aging processes. For example, senescence. Very often this is being called zombie cells. Zombie cells, which you and I have absolutely everywhere, I can tell you. You don't want to have them. You want to have little of them. So these are cells which are not dividing anymore, but which are still in your body. And they are in our heart, in our brain, in our skin. And it's very easy to measure. Take a little bit of the skin, put it under the microscope with, of course, a couple of interventions before, and you will see them.
Okay, and that accumulates as you get older.
Yes, so there's a little bit of debate, are they really accumulating or can we remove them, but you have more when you are older.
Got it.
And these these cells are more if you are aged, but also if you have a disease. So individuals with dementia have more of these cells, not only in their blood, but also in their brains. People with heart failure, people with diabetes have it more in metabolically active organs. So we now can really link not only it's accumulating or it's there with higher chronological age, but also with disease. And very nicely, already nearly 10 years ago, there was the first mice study. If you're removing these kind of cells with new drugs, that the mice are living longer and they don't have these age-related diseases. So really proving the causality. And the first study in humans came out, which was negative, which means did not really remove the senescent cells, was 4 years ago in individuals with knee pain, osteoarthritis. So it's a very, very good example while understanding with geroscience why we age. We can measure these kind of senescent cells. Give me a blood sample. I can tell you how many of these senescent cells you have. But then not only knowing that you are biologically aged, but also doing something about it and starting with animal studies, really removing these kind of cells. And there was the healing. And there was making at least a model organism living longer and then translating that into humans. So, which means you already hear my hesitation. It's not there yet for clinical practice because we don't have the randomized controlled trials actually showcasing that this is the case. We only have it not for the longevity indication, but also already in cystic fibrosis, for example, other more age-related diseases or very severe diseases, we already see that we can actually remove the senescent cell load while giving these drugs in humans. So it's really at the edge to become a longevity drug. So that's senescence. And then we have at least other of these hallmarks like telomere attrition, which is, I think, the least relevant at this moment in time. But very often people know telomeres. You want to prolong your telomeres. I can tell you that don't die because of the telomeres.
Okay.
Mitochondria, which are your energy. You already mentioned NAD and NMN and all these kind of supplements which are interfering with it. But also for example, the genome, how much breaks you have, how clean is the book you can actually read. So how many copy failures do you have? And then many of these kind of mechanisms we now understand and we can measure and we can translate into therapeutics. And there was really say this is a causal
so
aging
really
mechanism.
Treating the cause of aging or the disease of aging rather than just treating the symptoms of it.
Yes. And there you have, again, in the definition of healthy longevity medicine, it's exactly that. It's optimizing health and health span while antagonizing the aging processes across the lifespan. So here you see the root cause. Yes, we understand the aging process. And that is being based in geroscience and then expressed as the hallmarks of aging.
Let's go to gerodiagnostics. I think most people will be very familiar with the idea that biological age and chronological age are different. And they may well be wearing whoops and things like that. We'll be able to tell them what their biological age is. When you are speaking to patients and they have something like that, I mean, one of the things I think is a problem is that often they'll go to their doctors with that information and the doctor will go, well, no, let's do our own. And I think that's a bit of a problem on our side, that we need to stop doing that. But also they probably will wonder, well, what's the difference between the result I get from the Whoop? What's the difference between the result I get from the direct-to-consumer age clocks that you can buy? And what's the difference between the ones that I would get if I came to your longevity clinic? So can you speak about that a little bit?
Yeah. So first of all, if you have an appointment with your physician, it can be internal medicine, it can be GP, family medicine, just ask them, can I show you my sleep results? And just see how they react. Because I think in 2025, you are not a good physician if you don't ask yourself. And if you're urged to see it, you cannot interpret it. So make the choice who you are actually trusting. And of course, if they don't know it, do it again. After the third time, I think I would switch the doctor. Because it's so important. And they should they should ask directly. And it should be in your electronic medical record anyway. So then to consumer devices, tests, like I now mean the digital biomarkers of aging. So your Oura Ring, the Whoop, or the Samsung, that's really what the GP should know. Then we are talking about other tests where you send a drop of a blood to somewhere to get something back. That's actually what it is. I really think that it's not the time of consumer devices and consumer tests yet.
Right. So we should not waste our money on those.
I don't say that they are not accurate, but I think that somebody needs to sit next to you, which should be your GP or your physician, and say, this is the consequence of it. Let me first interpret it with you, like this is the meaning, and then do something. Because now we know that we are 52 instead of 48 or 38 instead of 62, whatever it is, then the so what. And that's also the reason why very often now the digital consumer devices, so the Auras, the Samsungs and the Apples, and that in the first weeks you love it because you can track, and then the so what. That's also the reason why I say, ask your physician if they want to have a look, because there should be an action, because it should be translated to all the other lab values.
Yes.
Think about your glucose level, or think about an insulin level, your VO2 max, even it's estimated and quite roughly not accurate, a VO2 max, and can give you a trend, and it can give you a wake-up call. So, but then what is a VO2 max? What can you do? And have somebody next to you say, maybe a little bit more of zone 3 or even zone 4 is good, or a little bit more resistance exercise training. And I will actually measure again and come back. And I want to see where you are in 6 or 8 weeks or 3 months.
Yeah.
And then it makes a difference. Just knowing with whatever inaccurate or accurate consumer device of what it is, I think does not make much sense.
So it's more of a trend that we're looking at.
It's a trend, but it's also, what do you do with this trend? Very often if I have conversations and I ask people, what do you get out of it? And then you get the number. But what do you get out of it? Like, what do you do with it? I don't know. Sleep better? Yeah, but then how? And being accountable to that how and how you do it, how do you tweak it, there's, I think, the magic. And that's the reason why we have healthy longevity medicine. And I don't want to medicalize every step we do.
Yes.
But very importantly, we are at the edge that for me, sometimes it's very hard to understand the unique biology of everybody, the uniqueness, how the biology reacts with the ecosystem where somebody lives, the environment, or the mental state, what somebody wants to achieve, the personality type. It's very difficult.
Yeah.
How can a consumer do that? With just getting, oh no, my microbiome age is 52, and you even do not know if that's a valid number or not.
Yes. What are we aiming for? So I think, with any other risk factor, lipids, for example, as doctors, we've got a target. We've got normal targets and we've got optimal targets, but we know where we're going with it if we're prescribing a statin. Is there, in your clinical practice, a number that we see? So are we looking to be 10 years younger, or are we looking for the rate to be X amount? I mean, I think obviously it's going to be very personalized between people and depending on their goals, etc. But is there something that we're aiming for that you would say, right, you are doing it well?
So you already said it depends on what that client wants. And this wanting is one thing, but then it's time investment and it's also financial investment.
Yeah.
And most of the people are struggling not with the financial investment, but are struggling with the time investment and actually doing it.
Yes.
And sometimes it's even not time, but it's really then the nudge not doing it or the nudge doing it. So the compliance is hugely important here. So what is the best outcome for you? It depends on many factors. So I'm not sure if you know your genome, but knowing, okay, so good start. So you just have to do a very good genome test just once in your life. If you're going to a longevity clinic, says, okay, I want to do it again, just close the door and go again, because your code book in principle will not change. Okay. The type how it's being measured can change, so we can be even more accurate, but don't do it 3 times 2
it's
times
not part
a year.
of your annual health check.
No, of course not. So do it once now with the technology, and maybe in 10 years or 5 years, we know better. So know your genome, because in your genome, it's being written what you could be. You in a certain environment, the exposome, and you with your mental capacities and your wishes and your dreams. So knowing that genome is for us at She Longevity very important, because it's the fundamental thing what we can read.
Yeah.
Then you have the choice, if you are reading, if we now compare the genome with a book, which chapter we are going to read and which one we don't read. So we can now switch on and off genes, and that's called epigenetics, where we have, of course, it's not, we cannot manipulate genes directly, but we can make a genome being read being used quite adequately with lifestyle interventions that we say you are now using the juiceful genes, which is great. Once we achieve that, we are looking at the microbiome. What are the bacteria living with you? Should be your friends. Don't harm them. How do you nurture them?
Yeah.
And then seeing, while having the first results, what the potential actually could be. So the trajectory of the first 3 months really determines what the end game could be. Not everybody can run a marathon twice a week and shouldn't, by the way. But independently, the magnitude of what somebody can achieve is what somebody is really doing and based on their biology. So is 10 years biologically older or younger better? Maybe 15 years for some, maybe 20 years. And just take into mind that we are comparing you with the peers.
Yes.
Do you want to be compared with your same age group? Or do you want to action as if you would be 20 or 30? So that's very important. So just being younger doesn't mean that you really reach the goal, but you can also say, okay, I want to function as I would be at the age of 30.
Yes. And tell me, so how much of the dial can be turned just by being incredibly meticulous about lifestyle medicine and preventative medicine, good old preventative medicine? How much more does longevity medicine give you?
So lifestyle medicine and preventative medicine, in my view, very often is related to annual health screenings. That's especially the preventative part. Very often just looking at you at this moment in time. And after 365 days, you're coming back. And very often it's not even taken into account how you were a year before. And that's no criticism. It's a very, very good step. Everybody should do annual health screenings, but I think we can do better.
Okay.
So we can do better while actually seeing, where were you 5 years ago? What is the trend line? And can we already optimize before that trend and that line, the downhill line, is actually occurring? Diagnosing diseases much earlier is very good. So out of the annual health screenings, the pre-diabetics, very good, very good. But we can do better. Why shouldn't you invest in your glucose metabolism at the age of 20, 30? You really don't have diabetes of most often, not in the next 20, 30 years. But can you already seeing, for example, with a continuous glucose monitoring system, the early signs of dysregulation, and not just doing an OGTT, an oral glucose tolerance test, but can you really integrate understanding your physiology while understanding also your habits with the digital devices? Can you combine it to predict what's going to occur over 10 years during your annual health screening?
Yes.
Being preventative health.
Yes. Okay.
Then lifestyle medicine. Lifestyle is huge in terms of an effect. Very often we stick also in lifestyle medicine towards you have to eat less, move more, and these are the good grains, and that's actually it. How can we really understand what that bacterium, one or the other, now needs in your gut? So including new techniques like a microbiome test.
Yes.
How can we feed the ones who really needs to be fed and distinguish the ones who are not good? That's then going into the precision, I would say, lifestyle medicine and using that. So in healthy longevity medicine, we first diagnose a lot. Very often I hear, okay, you are diagnosing too much. It's fine. I think we are at a stage where we can do too much to gain more in the end and to learn. So it's really a learning exercise too, which is very different to the WHO guidelines or the guidelines in lifestyle medicine. I think 80% is really generalized. Like, we know what we should do. It's why we don't do it. And then 20% is really the fine tuning. What really works in you? How can we nourish the short chain fatty acids production? How can we really stimulate to produce a little bit more vitamins in your gut that you don't have to take the supplement? And that's really the precise way we can use lifestyle in the new approach, how to treat your body, which every nearly other non-medical specialty. Think about electric cars. They have dashboard. They are engaging. Think about the Formula One.
Yeah.
You actually know when something has to happen. You have to make a decision when to I don't know, look at the engines or whatever they do.
Yeah.
But it's so precise.
Yes.
And I just want the Formula One dashboard, please,
Yes.
for all of us.
Okay.
And then everybody can make the decision informed. I'm going to invest in it or not, and I leave it.
What age is your ideal longevity patient? We already said that it's for adults only at this point.
Yeah.
But what age do you think in the new paradigm, once we've shifted towards this model, what age are people going to start thinking about this? Because in traditional medicine, really, people wait till they're 40 and they go, right, I better go and have a health check. And they start then. But what are you trying to say to the public about when healthy longevity medicine should start?
Very often we see individuals at the age of 40 to 60 coming to the clinic. And the only thing we say next time, bring your children. Because then you know what your trajectory looks like.
Mm-hmm.
So starting early is the essence.
Yeah.
Starting even a child, of course, measuring the weights, measuring the body composition is so important. Yes, but we will not intervene at the moment because we don't have the evidence. But get to know yourself.
Yeah.
And that's so important. Why should you wait with knowing your genome when you're 40? Like, to start at birth.
Yeah. Part of the heel prick testing.
Of course.
Yeah.
Of course.
I agree.
And very importantly, think about already of the next generation while you are working on yourself and you want to become pregnant. Hugely important because it's not only your genome, but it's how it's being shaped, what kind of genes are being used. We know from the Dutch hunger winter study, we know from many other cohorts that the health of the individuals becoming pregnant and being pregnant are such a big determinant of the health of the next generation, which is so much imprinted that even the ones who had lots of hunger during the Dutch hunger winter, that these individuals, the offspring, that they have lots of diabetes at the age of 50. So there is so much imprinting. So care about your health and your body and your mental state in every second of your life.
All the way through. Yeah.
But it's never too late. So also, if you are 90, in the wheelchair, there is potential in you.
Yeah.
And it's so nice. I can talk about it because I did studies in geriatric populations in nursing homes, and they were able to regain functionality. It's so amazing what the body can give if you just do it in a way, in an evidence-based way, and you are going for it. You have lovely stem cells in your muscles. You have lovely stem cells in your gut. Just a lovely system you should use.
Yeah, amazing message that it's never too late for longevity medicine, even if you are older than you think you should be. So let's talk about gerotherapeutics and some of the things that people may have heard about, like I mentioned in the introduction, but might not really know what they are. So NAD, talk to us about that. What is it? Why is it a longevity intervention? And should people be having it?
NAD is not a longevity intervention, it's an outcome.
Okay.
So NAD you can measure, and especially NAD plus in the blood. Think about your cells. Cells need energy. Where do they get the energy from? And they get it from NAD precursors. They're not only getting it from food, but it can be being made by our gut bacteria, which is lovely. So we need precursors of NAD to get our NAD levels up. You can imagine that NAD is nothing else than your battery sign in your smartphone, right? How much you have. So therewith, NAD precursors should only be given for the ones who need it, because who is charging their smartphone if it's 100% charged? Or who is charging their electric car if the electric car is 100% charged?
Yeah,
like
we
you
all
are
know
damaging.
not to do that. Yeah, exactly.
Yes, but you are damaging your battery. So think about the battery in yourself. First of all, you have to measure, is your battery full How full? Where is it? And what is the quality of the battery? Can you actually charge hugely because you have the capacity to repair? Or do you have to charge gently? So before giving NAD precursors, and most of the times we are talking about nicotinamide mononucleotide, for example, NMN, you can buy it as a supplement. I wouldn't advise anybody to take it. I would first measure your battery state, which means NAD+, and then you can actually see if titration of certain supplements like NR or NMN will actually help you to recharge the battery, which also means it should be measured again. Should you do that at home? I don't think so. Okay. So don't take the supplements just because it's nice and the label looks great, but really get advice of a physician who understands how to measure, giving it, titrating it, and measure it again. And also ask yourself, but the physician should ask you, how do you feel? Is your VO2 max better?
Yes. Okay. Good advice.
And don't do it via the infusions. Oh, very important.
Yes, this is a really great point. Go on.
So when I'm talking about NMN or the supplementation with NAD precursors, I'm talking about tablets, talking about capsules to orally being given. So there is the practice at the moment in many clinics who just say it's easy, quick and easy, and dirty, I would say, and especially dirty. You just give it via an infusion and a huge amount of energy. There's only a couple of studies, and one in particular, which actually did not bring the evidence that it's actually useful. And we only have studies with oral supplementation. And also from a physiological perspective, it does not make sense. I wouldn't know what so much of NAD precursors which actually do in the bloodstream, because it has to be resorbed. We have to feed our microbiome. And if you're giving it via the infusion, like no microbe will actually touch it.
Right.
So important to give it orally, but only give it if you really need it, because the non-responders, at least in our trials, are huge. So roughly 40% do not respond because your energy it's not your problem.
Right.
Take something else, but take advice.
Okay. What about peptides? We hear that a lot. What does that actually mean, and what can it do for you?
Yeah, peptides are great. The best example is GLP-1 receptor agonist. It's a peptide. Yeah, amino acids, peptide. Great. There's an entire peptide world out there in the longevity space. I very often do not understand even what the abbreviations mean, because they are, first of all, not tested, and secondly, which is even more important, not regulated. Which means that there are not fatal incidences, we don't know them, but there are incidences where people have to go to the emergency department because of cardiac failure, because of many failures of organ system. It just happened during one of the conferences where everybody was, not everybody, but the ones who wanted, injected with the peptides. Don't do it. Like, let's do the proper trials. Peptides are great. We have so many examples with the greatest on earth, the GLP-1 receptor agonist, but it went through proper design.
Yes.
And especially you have indications. So I love all the excitement. I love that people are nearly doing it, but don't do it irregularly, because you don't know what you're actually taking.
Yes.
So let's also hear the audience, please reach out. Would love to do a peptide study. And peptide is just a big bunch of molecules. So let's be very concise of what we mean with what peptide, when, and for what indication. But yeah, medicines are evolving. So also the peptides. But don't go and just inject the peptide wherever.
Last one, stem cells. Where are we with that? Ready to use, or something for the future?
Stem cells are great. My best friends, hopefully also your friends. You just have to make them happy. You have to take stem cells and bring them in a good environment. So hopefully you are nurturing your stem cells everywhere in your body by getting rid of a little bit of senescent cells, while not eating too much processed food, etc. So stem cells are a fundamental essence. It's one of the hallmarks of aging, which is great.
Yes.
So then the question arises, can we just take the stem cells, multiply them, and inject them again, and will we be younger? So that's not absolutely, it's not proven. So there are a couple of indications where stem cells have a positive signal, for example, osteoarthritis, where you are giving stem cells within you're injecting it within your knee to really make sure that the cartilage is growing again, etc. And there seems to be quite a good number of evidence-based studies showcasing good results. If there is evidence for one indication, it doesn't mean that it's good for a longevity indication.
Yes.
So there is no longevity indication. There are a couple of trials in the making. Hopefully they will showcase if there is evidence or not, and what the evidence shows. At the moment, very often it's being cited by one study where individuals being pre-frail to frail at the age of 70, 75 were injected with 5, 10, and 20 million of mesenchymal stem cells. And the group of 10 million, they had the best increase in walking speed, whereas the 5 and the 20 did not.
Oh, wow.
You already see that I didn't mention the placebo group. So there was no placebo group, and the individuals being included, the analysis are done on 5 individuals, and 15 were included originally. So I don't know what to actually and how to judge the study.
Okay.
So there is evidence of quality which should be absolutely better, and we don't have the indication for longevity. So I would again here it's everybody's choice where to put their money. If it's evidence, if it's evidence based, if there is knowledge around it shared, go for it. I would never provide it for my patients at this moment in time, because it's absolutely not right. Even the protocols are very often not shared. You don't know where the mesenchymal stem cells are coming from, and don't use the cheap ones, please. Not cheap, but cheap, like from the cheap.
Yes.
Like the animal.
Oh, sheep.
Yes.
Right. Okay.
Yes.
Okay.
Yes.
Got it.
And the same also for the exosomes, which are actually secreted. Don't use the animal ones, and it can be quite harmful, because you have the chance for the stem cells, but also the exosome treatment, to come to the emergency department with a lung embolism or a deep venous thrombosis, or with bacterial or fungal infections.
Goodness. Okay. So that's the information that it's difficult to find on podcasts, that kind of balance. Well, this could happen, but actually we don't have the evidence, and these are the downsides. What's your advice for, last question, what's your advice for people out there who are interested in longevity, who want to kind of explore this more, but don't have access to your longevity clinic, don't know whether the longevity clinic they see is evidence-based? What's your advice for them?
There is a new registry being launched by Longevity Technology, and that's Longevity Clinic World. Have a look at the website, and the Healthy Longevity Medicine Society is providing the grid to actually judge or give an indication. We don't judge, but it's an indication on which evidence level that longevity clinic is actually functioning.
Amazing. And that's worldwide?
Yes.
Brilliant. Okay. Well, thank you very much for all your insights. It's been a fantastic conversation. And I hope that people have left this kind of having more of an essence of understanding of the essence of healthy longevity medicine without the hype, and understanding that it seems to be the future of healthcare.
Not the future. It's there.
It's now. Yes, it's now. It is now. All right.
Thank
you very much for coming in. And that's it for us. I'm Dr. Natalie Hutchins for the Women's Handbook podcast.
The content of this podcast is for educational purposes only. It is not intended to replace the doctor-patient relationship, nor does it constitute personalised medical advice. If you are affected by any of the topics discussed, please speak to your doctor or a qualified healthcare professional.